the visual field as the island or hill of vision surrounded by a sea of blindness. The historical basis of perimetry dates down to 150 BC by Ptolemy, who described the shape of the visual field as roughly circular, downwards to 1945 when Goldman described the hemispherical bowl perimeter. So perimetry is important to identify a field defect, a visual field defect, and determine the cause and also disease progression. The role of perimetry in glaucoma is very important, linked to the definition of glaucoma, representing a group of diseases with characteristic optic neuropathy, and functionally, the distinctive patterns of visual field dysfunction. So herein lies the importance of perimetry to glaucoma management. Visual field is ideally a three-dimensional structure, and it can be measured in two ways, static or kinetic. The kinetic perimetry is usually measured along the XY axis, and usually requires a perimetrist. This method is not favored as much as the static perimetry these days. The static perimetry endeavors to measure the visual field, attempting the three-dimensional zone by involving the Z-axis, which is perpendicular to the sea of vision. Currently, the method employed as the gold standard is the automated static perimetry. So most of our discussion here will be focused on the automated static perimetry. Just can you move? Okay. So we'll move on to interpreting perimetry results. To interpret perimetry results, it's important to identify that there are 10 zones in the perimetry, starting with patient data, test data, and also reliability indices, raw data, grayscale, and then we move on to the total deviation numerical point, as well as the total deviation probability point, the pattern deviations, the global indices, and the glaucoma field tests. So this presentation will briefly talk about what we should look out for when interpreting a perimetry. It's important to adequately fill patient data by the perimetry. It's also very important to fill the tests that are being done. Adequate filling of patient data correctly is important for documentation, as interpretation of patient data is age-matched to the normative data on the machine. Pupil size is important. Normative data use pupil size of 3 to 4 millimeters, so it's very important that pupil size is about that size. Constricted pupils is not unusual to tell patients to go back to get their eyes a bit dilated or stop use of myotics before their visual field test. Stimulus size and background illuminations are almost always a constant parameter. When we look into the reliability indices, we start off with the fixation loss parameter. This talks about the patient's gaze stability. This is important. There are different centration factors. It could be the central fixation targets, which are yellow, or it could be the fixation diamonds, which are lower down, which are the diamonds, the small diamonds, or the light diamonds. It's said that the fixation loss greater than 20% is unreliable. Fixation loss is usually tested two methods, the ideal crackerel or the gaze tracking method. This is the gaze tracker that shows that the patient lost fixation in the second picture, in the second diagram here, and then the patient had a lot of multiple blinking, which is represented by the downward spikes. This picture is there showing that when we are interpreting a central visual field test, it's important to determine the position of the blind spot. As is seen in this second picture, where the blind spot for this patient has come down from where it should be ordinarily, which is on the horizontal meridian, about 12 to 15 degrees temporal. This is important in determining the validity of this test result. We move on to the false positive and the false negative. The false positive, iconically, the trigger happy patient that keeps on pressing without the sound. 20% is significant. And then also the false negative patient who has been able to respond to stimuli but doesn't respond anymore. These patients are usually the ones that are tired or are fatigued. The raw data just gives us an idea of the retinal sensitivity of each patient. And then it's important to understand that the retinal sensitivity is inversely proportional to the light sensitivity. So what that means is that looking at the raw data scores here, a patient that has a high retinal sensitivity is about 30 and 40 requires a little less of light intensity for him to be able to appreciate the presence of the stimulus. As we go on, we see that the raw data is also interpreted to the grayscale. So the grayscale is just a pictorial, graphical representation of the raw scale. There's nothing scientific about it. It's just the form that tells us when the retinal sensitivity is high, the scores are in the bright picture, and when the retinal sensitivity is lower, the pictures are darker. The total deviation numerical point helps us to define the retinal sensitivity of each patient and compares it with normative data. So it's we can roughly say that total deviation numerical plot is the raw data, that's the raw retinal sensitivity data of the patient minus normative data. There are three possibilities. It could be negative, where the patient has a reduced retinal sensitivity. It could be zero, where there's no loss of retinal sensitivity, and it could be a positive sign. Then we move on to the total deviation probability plot. This is an expression of the loss of retinal sensitivity in comparison to how much of this is seen in the population. For patients that have the darker spots where the retinal sensitivity is about 0.5, it means that this retinal sensitivity chart of these patients can only be appreciated in 0.5% of the population. And then the P less than 1 is seen in only 1%, and so forth. So moving forward, we go on to understanding what the pattern deviation tries to explain. The pattern deviation simply tries to explain the removal of the presence of generalized depression from the total deviation normal plot. So what this means is that we attempt to find the 7 best sensitivity in the total deviation numerical plot and add it on to all of the numbers and get the pattern deviation. So essentially, the generalized depression is all of the depression of glaucoma. But the pattern deviation attempts to see in all this darkness, is it just the media opacity or is there glaucoma involved? So pattern deviation probability plot helps us to determine when you remove the presence of generalized depression, is there some glaucoma field defects as well? And then I would just go to this slide, the zone 5 to zone 8. Briefly, I'll just say that what this zone 5, like the total deviation numerical and probability plot, as well as the pattern deviation numerical and probability plots, try to explain clinically in our daily clinic life is that when we have a patient that has a generalized depression, we want to see whether it's uniform or irregular. When it's uniform, then we know that the cause is mainly a media opacity, mainly caused by conditions like cataracts. And when there's an irregular one, it will be because of glaucoma. So the mean deviation, the global indices, the mean deviation is important. It can help to classify glaucoma into mild, moderate, and severe. And then it can also help to decipher whether a glaucoma, in the case of disc asymmetry, is the glaucoma present or not by these factors as well. The pattern standard deviation helps in diagnosing early glaucoma, but it's no longer useful with late glaucoma. With early glaucoma, we can see in this picture where I compare a patient with early glaucoma and late glaucoma. We see that the pattern standard deviation is about the same value, but the mean deviation has increased. So I would like to end by talking about the glaucoma image field test, which are self-explanatory, and then importantly, the Anderson criteria to diagnose glaucoma in the presence of a cataract. The PLs for glaucoma are important because it's mainly a subjective test. requires team approach, mainly from the doctor, the perimetrist, and the patient. Adequate patient counseling prior to the perimetry is important. Adequate patients by the perimetrist and explanation to the patient is also important, and a positive patient behavior is important. The pitfalls in perimetry are diverse. They include the patient, the perimetrist, and the doctor factors. In conclusion, I would like to say that the landscape of ocular imaging is evolving, and there's a lot of fast-paced ocular imaging being released, but perimetry still remains a cornerstone in patient management. Moving onwards, we would like to emphasize the role of perimetry in patient management and precision. Thank you very much for listening.
Thank you very much, Dr. Odubela.